Thank you very much, and I appreciate the opportunity to be here to speak with you this morning. I'm sure Dr. Wormer's had the same problem of what to talk about when you have 20 minutes, especially for a topic like osteoporosis. And so my title is trying to reflect how I approach this, which is what's in the news? What are you maybe hearing about through patients or seeing yourself in the news? This is within the last 2 or 3 years, and I think these actually do reflect the conversations that are happening in practice. And therefore, I hope that with this discussion, you'll have some ideas to take home with you. So I have no disclosures. One of the key things I want to define just in terms of terminology, so we're on the same page, is primary versus secondary prevention. So primary prevention being we're identifying an individual at risk and we're treating them with a variety of measures, perhaps medication, to try to reduce the first incidence of an outcome that we don't desire, like fracture. So primary prevention of fracture. Versus secondary prevention, the idea that the patient presents with the disease. They present with the fracture, and our job or our intent is to prevent recurrent fracture. So primary and secondary prevention. And these are the themes I'm going to really be focusing on quite a bit in my discussion today. So last year, this editorial came out in the British Medical Journal from Dr. Jarvinen and colleagues that was part of a series of talks or papers on overdiagnosis. And in this case, they were making the case that osteoporosis is overdiagnosed and overtreated. And this is not a new theme for these particular authors, by the way. They've had this theme in mind for several years, actually, but this was the most prominent article that they had written to this point to a wide audience and created some friction with some of the professional societies for osteoporosis nationally and internationally as well. But their point really was that they felt that what had happened over time is we had gone from identifying patients with screening tests like bone densitometry and defining them based upon having fractures, and broadened the number of patients categorized as benefiting from medications by using estimates of fracture risk, or the WHO fracture risk calculator. And that overnight, by making that major change in how we select patients for therapy, we've more or less doubled the number of people who are eligible for therapy without validating that that's actually an effective approach, which they presented a lot of data suggesting that it wasn't, and you could imagine much data was presented that suggested it was. But regardless, just calling into question primary prevention. Is this really valuable or not? They're particularly concerned about older individuals, men, particularly concerned about younger patients who are eligible for treatment as well. So what were they doing? Well, again, this is the tool. You're familiar with this tool most likely. Whereas before, the patient who had a T-score of minus 2.2 would not be defined as having osteoporosis. Now with a risk factor such as a parental history of hip fracture, now has a risk of 31% in 10 years, and this is above the threshold defined by national